Hello, everyone, and thank you for tuning in to the HPHR Journal Insights podcast. HPHR Journal is an independent academic referred journal that seeks to improve health equity and social justice through the publication of content grounded in thoughtful evaluation of evidence. It is published by the Boston Congress of Public Health, a nonprofit organization that addresses social change at the nexus of public health, health equity, and social justice. This podcast delves into articles published in HPHR Journal that address complex public health issues in an effort to affect social change. My name is Riva Bajuri, and I will be your host. Today, I'm joined by Dr. Jennifer Myers and Dr. Sulaire Telford, co-authors of A Preliminary Report of Trauma Impact on Language Skills in Bilingual Adults, a case for trauma-informed services. Their article can be found in HPHR Journal edition 62 on mental health, available on hphr.org. To start off, please introduce yourself, your professional background, and the content of your research. Why don't we start with Dr. Telford?
Hi. Hello, everyone. My name is Dr. Sulaire Telford Rose, and I am a speech language pathologist by trade and an assistant professor of speech language pathology at the University of the District of Columbia. My research interest looks into culturally responsive assessment and intervention practices for working with people who have communication disorders.
And I am Dr. Jennifer Myers. I am a medical speech language pathologist and neuropsychologist by trade. I currently serve as founder and president of a small nonprofit called the Raymond Banks Away with Words Foundation, which strives to provide community focused expressive arts programming as well as communication, health, equity. Happy to be here today.
We're happy to have you. Thank you so much, you both. My next question is why both of you chose this research topic.
And I'll start by saying that one of the things that drove me to this research is that we did not see in the literature related to trauma many articles or work that really delved into working with multilingual, multicultural populations. And we wanted to see how, what the challenges were for bilingual individuals specifically. I'm drawn to research like this because very early on, I realized that there was an intersect or interplay between culture and language, and we really cannot divorce one from the other.
Definitely. Thank you so much. Dr. Myers, anything to add?
Yeah, I think it's such a relevant topic, especially as we talk about things like trauma informed services and how just the importance of interdisciplinary and transdisciplinary approaches in that regard is just really instrumental. And again, given my background as both a speech language pathologist and neuropsychologist, it really hits home to me as well.
Of course, thank you. And Dr. Telford, you kind of touched on this, but that brings me to my next question, which is, can you discuss some of the literature that inspired your research and what were some surprising results of your research or literature review?
Mhm. Well, so in the field of speech language pathology, as I mentioned, and you referenced, there wasn't not many articles or much research that even talked about trauma itself. But one of the founding researcher, seminal information on trauma and the intersect between trauma and language was by Dr. Yvette Heiter. We started seeing an uptick in that once we saw with the onset of COVID-19. But Yvette Heider really started talking about in 2007, 2009, or 2012 work as well about that intersect with trauma and language. And that kind of spurred my interest and spurred me on to delve deeper.
Of
And
course, thank you. And I was wondering if you would mind kind of defining what trauma is for our viewers.
right. So trauma can be psychological, emotional, physical. I think oftentimes when we think of trauma, we think, a head injury or a body injury. But in this context, we're talking about kind of the emotional and psychological implications of experiencing or witnessing something that is disruptive to kind of our worldview or perspective. So things like assault or a sudden death of a loved one, experiencing a natural disaster, or more recently for many of us, the trials and tribulations of COVID-19, the pandemic in general.
Of course, thank you. And so that kind of leads me to my next question, which is what are the possible mechanisms which could explain the relationship between language and trauma, and how has COVID-19 affected this relationship?
Right. There is such a I think really important relationship between language and trauma. We as humans, we use language, and language is so instrumental in our being. And so when we have or experience something like trauma, that's often reflected in our language, whether it's expressive language and the things we say, or in some cases don't say. Um, in terms of our receptive language. So, how we comprehend and understand what's being communicated to us in the context of experiencing trauma. And then it's something often overlooked when we think about language, but the social use or pragmatics of language, how we behave in communication contexts. To really drive this point home with examples, how someone talks about a traumatic experience, the words that they use, the fragmentation in their discourse can be affected by said trauma. You have research that shows even talking about non-trauma related tasks, but having post-traumatic stress or post-traumatic stress disorder can change the words that you use. In our research, we even found that individuals who may have had have been assaulted, they stopped using the language of their assaulter because it brought about traumatic feelings or experiences. You have others who are, due to their trauma, afraid to be in social context, which again kind of affects or impacts language. And so it's such a complex, multi-layered relationship between the two. And I think it's been brought to the forefront with the onset of COVID-19, where we see individuals, again, not going out for an extended period of time. So not being able to use their language, both expressively and in terms of pragmatics. You also have the fact that trauma itself can impact. So trauma of losing someone suddenly due to COVID, trauma due to financial distress due to COVID, and how that may play a part in the willingness, the desire, and enjoyment of communication in general.
So this relationship between trauma and cognitive language, do these impairments lessen over time? And if so, what kind of evidence do we have to support this?
Right. And I guess the great and not so great thing about it is this is all new and emerging, especially as it relates to COVID-19. And so a lot remains to be seen. I think the important thing is that we are, starting to really look at this and hopefully look at it long term. What I can say in terms of what has been established is that uh, more recently, I'd say probably within the past 5 or 10 years, we've really now understood and I guess accepted the fact that trauma indeed can impact cognition, with language being a part of that discussion. For so long, we kind of kept post-traumatic stress and trauma as a separate entity only to be discussed by psychologists. And we're now starting to learn, and as we become more trauma informed, as we start to do more research about the implications of trauma, that in fact it can have significant impacts on cognitive communication. There's been some research, for example, that's looked at military, active duty military who's experienced blast injury or traumatic brain injury, that has comorbid PTSD. And we're finding that the symptoms associated with TBI often are resolved short term, but that the impact of PTSD seems to be long term. So we're talking months and even years. And so it's going to be really important for us to continue the work and see the long-term implications of trauma and how it impacts cognition and related processes.
Of course, thank you. My next question is for you, Dr. Telford, and it is, what kind of intervention methods do you suggest for bilingual adults experiencing trauma-related cognitive language difficulties?
That's a really important question. I think it's one of beyond understanding the relationship between cognition, language among bilinguals, and trauma. The next question is absolutely that. So, what do we do? How do we do it? How do we provide appropriate assessment? I mean, interventions. Um, like Dr. Myers mentioned, there is little research out there to tell us what to do with bilingual individuals who've experienced trauma and cognitive language difficulties. But based on the results that came out of our research, especially, we suggest a culturally responsive approach that involves a transdisciplinary team. And
And
I,
so you
yeah,
you
go
men
ahead.
sorry. You mentioned transdisciplinary team, and I was just hoping you could elaborate on that and describe what a transdisciplinary approach is, how it's implemented, and what the benefits are.
Absolutely, absolutely. So a transdisciplinary team would be a set of individuals who can provide the clinical services that our client needs. And I'll name the different members of the team that we suggest. And of course, based on the client needs, the members of that team may differ. Right. So one type of professional that's very important is the psychologist. And typically, psychologists do what we call a psychosocial evaluation. They try to determine what are the biological implications for the client, what are the psychological, what are the social impacts for the client. And after the evaluation, that psychologist may recommend that the client receive services. And sometimes that service provider may themselves be the psychologist, or may be a social worker, right? And then the social worker would be a part of the team because the social worker is in the place to provide intervention for the client, to deal with all parts, the biological, the psychological, and the social impacts, to provide counseling, to connect them with possible services that they may need just to be able to survive. And another important part of the team would be the speech language pathologist. And of course, this is important to us, as this is our background in our field. So the speech language pathologist would focus on the communication difficulties that the client is experiencing. We might also have what we call an occupational therapist working on different elements. And another important element, especially when working with bilingual clients, is to have a cultural and or linguistic broker, somebody who really understands the language and culture of that particular individual, who can explain that to other members of the team. And in fact, that person would allow the team to really address the client and actually help with reducing re-traumatization, right? Because they understand a little bit more about the culture of that particular person. And of course, if no members of the team are bilingual themselves or speak the other language of the client, then we recommend an interpreter being a part of that team. And then one might ask, why not just have them work in their silos and do their work? Great question. When we work in our silos, especially as speech language pathologists, I can speak specifically about speech language pathologists. We, as clinicians, are not necessarily trained very deeply in understanding the impact of trauma, those things that cause re-traumatization, the triggers that individual may have. So working with a team of professionals who truly understand trauma, we can improve and enhance our approach working with the client, and vice versa. The psychologist, the occupational therapist, the social worker may not understand as deeply the impacts that trauma may have on communication or language, or be able to provide appropriate interventions. And the psychologists and social workers are all trying to get information from the client in a verbal manner. So the speech pathologist would make recommendations and work with those with the team, and really just help to enhance the service that our clients are receiving.
Thank you so much for that very detailed response. I just had a quick follow-up question. Would you mind just quickly defining what re-traumatization is?
Yes, I would, but I'm going to leave that to Dr. Myers, who is an expert on talking about this particular issue.
Yes, of course. So when we talk about things like re-traumatization, we're talking about certain what's a good word here, triggers or incidences that can have an individual kind of relive the trauma. And this is often expressed by things like hyperarousal. You'll often hear rumination is another term. So you're getting flushed. You have physiological things that are happening similar to what happened when you were actually in that event or trauma. So, for example, if going back to the example I gave earlier about someone not wanting to speak the language of the person that assaulted them, if they're working in receiving speech language services, and the speech language pathologist is trying to get them to speak, let's say, Spanish, and that is the language of their assaulter, that may trigger a re-traumatization, because now that's triggering the memory of that assailant, the person that assaulted them. That language is associated with them. So now they are really upset, distressed. And that could be, again, a physical manifestation, emotional, psychological manifestation of pretty much reliving that trauma again.
Great. Thank you so much for clarifying that. I think that's very clear now how that connects to kind of culturally responsive healthcare and such. My next question kind of is about culturally responsive healthcare, and it's how culturally responsive healthcare practices can be used to enhance the transdisciplinary approach.
Yes, absolutely. I can answer that. So maybe let's take a step back a little bit. The question might arise like, what does it mean to be culturally responsive? To be culturally responsive first means to um, not, historically people have spoken about taking a like a colorblind approach, and not, not seeing people through the cultural lens. And I think that's been detrimental to cultural responsiveness, because we all come with our individual cultures, identities, way of beings, understanding and perceiving the world. And that's a part of our identity, and our identity should be acknowledged. So it's acknowledging that each of us come with different cultural identities, right? Um, and when it comes to bilingual or multilingual population, that they come with, or we come with languages that are different from the societal language, that may be non-mainstream. So it's first acknowledging that. The second is to have a sense of humility about one's own culture. So we may be prone to think that those from who are part of the mainstream culture may have higher value, or their culture may be more important or matter more. And as a part of the transdisciplinary team, we ought to see that the way that our clients think and perceive may be different from the way we are going about the world, but doesn't mean that's wrong. So there needs to be a sense of humility, and cultural responsiveness means that we're willing to do the work. There's no point in time, and there's no one individual who will understand going in, working with any client, everything about that culture, everything about that language. But acknowledging that you don't know and doing the research, working with a cultural and linguistic broker. Um, and once we come from that approach, we can really enhance the services that we're providing to really truly meet the needs of our clients, and make them feel comfortable.
Great, thank you. Dr. Myers, anything to add to that?
I mean, Dr. Telfer Rose did an amazing job in her response. I think that as long as we put forth the effort and really just minimize the assumptions and know that this being culturally responsive is a journey, it's not a one and done, it's not a single continuing education credit or training class webinar, but that it's ongoing and ever evolving. So that's a bit that I'd add to that.
Absolutely.
Certainly, thank you. My next question is, what kinds of research should be conducted to better understand the role of trauma in cognitive language skill deficits?
Yes, this is such a really an instrumental thing, the research part of it, and application. I'll say that as well. So, in terms of the kinds of research, I would say there's a few things to keep in mind. Obviously, the number one thing is doing the research, asking the questions, and applying the outcomes and findings to those that we serve clinically. The next thing I'll say is along the lines of being culturally responsive, that applies to the research as well. And so, exactly what we did here is looking not just the impact of trauma on language skills in general, but how does that particularly affect those who are bilingual? We could assume that, oh, well, if if English is their second language, then that's going to be impacted. And as was our case, most everyone reported that both languages was impacted by their traumatic experience. And so part of the research is asking those micro questions or really getting detailed in the research, looking at communities and populations where from a cultural sense they may respond or be impacted differently than mainstream assumptions or even established outcomes. And then the third thing, again, speaking a little bit, and I might be a little biased here, but speaking to the work that we did in this paper, is understanding the concerns and the feelings and the needs of those we serve. And so making sure that the research that we produce is not just quantitative, but qualitative by nature. And using that to really provide a full scope or a comprehensive lens to what is really going on. That's the best way, in my opinion, that we can really increase the clinical outcomes and the progress in our intervention is by ensuring that not only are we looking at the numbers, but we're looking at the actual individuals that are being impacted. What are their concerns? What are the things that they are reporting are being difficult or impaired? How does that line up then with our quantitative findings, and what does that mean from a practical standpoint? And then the last thing quickly I'll note is making sure that that gets out there and is implemented in our healthcare practices. Research cannot just stay on paper. And so being able to use the things that we have studied, the analysis that we've run, the papers that we've written, and now putting that into practice. And so those are the things that we need to do. So after the qualitative research, the quantitative research, the type of research, the policy research, the standard of care research is equally important.
Of course, thank you. I totally agree with the importance of kind of conducting this person first research to ensure that definitely, even though there is a quantitative side to research, there's such an important qualitative aspect. My next question is, I guess, for both of you, what is your call to action for the audience, and what is your call to action for researchers specifically?
I think Dr. Myers kind of outlined that call to action. It's doing the research. We need to have research that's more inclusive, research that looks at diverse populations. And we know that our work is just the beginning, it's just really the tip of the iceberg. And we really need to go deeper. Looking at research on bilingual populations. One of the things that came out from our literature review is that some clients, and I think Dr. Myers had mentioned this, avoid speaking sometimes in their first language, or avoid speaking in the second language because that's the language that they experience trauma. And if you don't go in understanding these differences, we may not really truly be able to help the populations that we serve. So, doing the research on multilingual populations, multicultural populations, and understanding that even when the circumstances of the individuals that we serve differ from or don't even resonate with our own reality, that we ought to believe them and we ought to um, apply and change and modify to suit their needs.
Great, thank you. That was a great answer. So my last question really is, how does your research relate to health equity and social justice?
Yes, I think our work relates to health equity and social justice in a few ways. I think the first way, and what we've kind of spoke to during today's conversation, is really getting your hands dirty and reaching out to those populations and those communities that are have been marginalized, that are typically vulnerable, that aren't often heard, unfortunately, especially in the research space, and really trying to seek the answers for optimizing their outcomes. Oftentimes, these are communities and populations that are have higher rates of disparities when it comes to health. And so, by doing research that really taps into these specific communities and not just trying to generalize or apply uh, broad results to these, special populations, these priority populations, I think is crucial. And that's what we attempted to do here with this descriptive study. I think it also really speaks to the health equity and social justice piece in terms of really having a call to action of all hands on deck, if you will. So not leaving it up just to the psychologist or just to the speech language pathologist or just to the social worker, really emphasizing that in order for us to meet the needs of these communities, that it has to be all of us together working in tandem. And then the last thing I'll say here in terms of how our research relates to both equity and justice is that it's part of the larger kind of social health ecosystem of, again, hearing the voices of those that are impacted. So again, quantitative research is important and great and crucial, but I would argue equally so is the qualitative. So is hearing it directly from our clients and our patients' mouths, their voices, hearing what their concerns are, and letting that really drive the next stages of research. So again, this was exploratory just to see what the concerns and the reported impact was in this paper. And from there, it allowed us to really gauge, okay, for the next part of our research, for the quantitative part, based on their concerns, what should we be investigating so that we can build a more health equitable ecosystem and address some of the biases and maybe unfairness as it relates to research.
Certainly. Thank you so much. Dr. Telford Rose, do you have anything to add about that or last comments in general?
Yes, I'd say if you'd like to continue the conversation with us, you can reach us at research@culturallysmart.com. Or if there's anyone who would like to participate in our research in any way, we have a program called Culturally Smart, and you can find us on the website www.culturallysmart.com.
Awesome. Thank you. And Dr. Myers, any last comments in general for you?
No, I think everything summed it up. Appreciate the platform to really express our passion for being culturally responsive researchers and practitioners, and invite anyone who's willing to join us on the crusade to do so.
Yes, thank you for having us, Riva.
Yes,
Thank
thank
you.
you.
Thank you so much, both of you, for coming on to the show. It's really, really vital to be able to talk about these sorts of things. And at HPHR and the Boston Congress of Public Health, we really appreciate researchers like you and the work you're doing.
Thank you.